Good day, everyone. Welcome to the Medication Reconciliation Information Session. You may ask yourself, what is a medication reconciliation? A medication reconciliation is a process of acquiring a complete and accurate history of a patient's medications. This may include prescribed medications, over the counter medications, and vitamin and supplements. Information about these medications, such as the name, the dosage, the frequency, the administration route, and the duration of therapy, should be included and collected. So you may ask yourself as well, why conduct a medication reconciliation? So one may conduct a medication reconciliation to get a complete and accurate list of all current medications and supplements. This will also ensure that an accurate list of the patient's current medications is maintained and communicated between transitions of care. This will also prevent adverse drug events, such as drug interactions and drug allergies, and also a prevention of duplication of therapy. Furthermore, this will help in identifying discrepancies so that they can be resolved.
So now let's talk about the medication reconciliation process. Generally, you would start by developing a list of a patient's current medications. Then you would develop the list of medications to be prescribed. And then you would compare the medication on the list of the physician order with the list of the patient's current medications. After that, the physician will make clinical decisions based on the comparison. Then lastly, you would communicate the reconciled medication list to the patient and to his or her circle of care. For example, the patient's doctors, nurses, and family members. Now, who can conduct a medication reconciliation? Different steps of the medication reconciliation process can have their own list of who can complete the step. So for example, in step 1, or to collect, the step can be completed by physicians, nurse practitioners, nurses, pharmacists, pharmacy technicians, addictions counselor, and other disciplines. In step 2, or the comparison stage, this can be completed by physicians, nurse practitioners, nurses, pharmacists, and pharmacy technicians. And in the final step, or the correction stage, this can only be done by physicians and nurse practitioners. Now, where can someone conduct a medication reconciliation? This usually takes place in 2 situations, during admission and discharge. So for during admission, usually medication reconciliation is done in inpatient units, and these are typically for new admissions to the hospitals, or it can be done in the emergency department or the surgery and preoperative clinics. During discharge, medication reconciliation can take place in homes or retirement homes and in long-term care facilities.
When should a medication reconciliation be conducted? It will be an admission, transfer, discharge. When you look at for admission, the goal of collecting a medication reconciliation during a patient admission is to actively make a decision in regards to continuing, modifying, or discontinuing medications already taken at home. These are referenced to the admission orders. When you look at transfer, the goal of collecting medication reconciliation during a patient transfer is to actually look at the medication received upon transfer. The medication reconciliation and the medication admission record are referenced to the transfer medication order. When you look at discharge, the goal of medication reconciliation during the discharge is to resolve any discrepancies or modifications regarding the medications pre-admission to post-discharge. The medication reconciliation and all medication administration records should be compared to the discharge order to ensure all changes are intentional. Phase 1, collect some medication list. The list of home medication can be very extensive as a patient may be taking a variety of medication ranging from prescribed dose drugs, OTC medication to supplements, also have different dosage form. Therefore, this is the most time consuming and the most challenging one to collect. For example, rosuvastatin, perindoprol, Ventolin inhaler, vitamin D. Phase 2 is compare. At this stage, BPMH, which is best possible medication history or the home medication list collected by a healthcare professional, will be compared to the updated medication order list to see if there are any differences. This is particularly useful in situations where no secondary source is available or when the patient, guardian, caregiver cannot provide a complete and accurate list of medication to the patient is on.
Phase 3 is correct. Keep in mind to be extra careful when correcting care plans because not all discrepancies or modifications need to be fixed or corrected. These changes are often done to carry out the best treatment plan for the patient. Please note that only MDs are able to correct discrepancies or update orders. So you might be wondering, what are some common discrepancies to look out for? Well, medication discrepancies can be significant and lead to adverse drug events, medication errors, drug therapy problems, and preventable patient harm. There's 3 types of discrepancies. The first one is intentional discrepancy. The prescriber intentionally made this discrepancy to meet patient's need with documentation of the intended change in the clinical record. For example, a patient is admitted with pneumonia and started on antibiotic, which they were not on at home. The second type is an undocumented intentional discrepancy. The MD intentionally chooses to modify medications on an order without documentation, which leads to discrepancies between the best possible medication history and MD orders. This may occur with items like multivitamins. And the third type is an unintentional discrepancy, which is accidentally made by the physician or pharmacist or lacks documentation in the clinical records. An example may be a patient's PHAR that they were taking for COPD. The best possible medication history is the history of a patient's medications collected by a healthcare professional, including both prescription and non-prescriptions. There's 2 required components that are mandatory as part of the best possible medication history. The first part is the systematic patient interview, and the second part is information from secondary sources. An example of secondary sources is a medical history of the patient from a reliable source. For example, a pharmacy-provided medical history, medication labels from drug vials that patients have.
So some reliable sources may include patient's medication vials, packaging, any previously documented list of the patient's medications. So some official document lists, such as a patient's handwritten list, is considered part of the interview, and it's not considered a secondary source. Another source is the Ontario Drug Benefit Profile, especially for patients covered under ODB. Of course, patients who do not have coverage under ODB will not have a profile under ODB. Another one would be the Institutional Medication Administration record, or the MAR, or even from the patient's community pharmacy. But please be aware that patients may use more than one pharmacy, so they should be asked if they use multiple pharmacies. Other sources include some coming from the physician's office or even the prescription that the patient is given, and also the patient's primary care provider, such as the family medical doctor. In addition, previous completed medication reconciliations done in the past, or BPMHs, and also looking at their previous health records are good reliable sources to go to. Now here's some tips to get a complete BPMH. 1, try to collect medical information before interviewing the patient. So this includes looking at the drug vials, their medication history, and also the provincial database information. Number 2, ask about any uncommon dosage form of drugs, such as eye drops, inhalers, sprays, patches, and nebulizers, like those found in children. Number 3, do not assume patients are always following the directions ordered by the physicians. Always ask how they are taking the medications. Number 4, ask open-ended questions. Don't ask questions that is simply a yes or no answer. So some questions would be like, how do you take this medication? Number 5, pay attention to the details as to when the patients filled their medications in order to see whether the patients are compliant to the treatment plan. And number 6, verify the information that you've collected with a trusted source, such as the pharmacy or the patient's family doctor. This is the end of the medication reconciliation informational session. Is there any questions? Thank you for your participation.